Welcome to the Highland Waves podcast, coming to you from Marshbrook Studios, located on a bank of the world-famous Margaree River in Cape Breton, Nova Scotia, Canada. On Highland Waves, we feature stories about the people, the places, and those who come to visit us here in Inverness County. I'm Pat Wall, your host. This afternoon, I'm pleased to have with me here in the studio Dr. Mark Bennett, a stalwart of the medical team at the Inverness Consolidated Hospital here in Inverness County. Welcome to Highland Waves, Dr. Bennett.
Thank you.
I understand you came to the medical profession after receiving an engineering degree.
Yes, from University of New Brunswick.
Oh, okay. So that's where you studied it? Are you from there?
No, I'm from Hillsborough, south of Moncton.
Oh, okay. Did you practice engineering for a while before you going into medical?
No, I never had a real job.
Okay. What inspired you to change professions?
Well, I didn't think I'd ever actually get into medicine, so I thought I'd study engineering so I could have a fall back.
Okay.
Yeah.
And why did you choose family medicine?
Well, you get to do a little bit of everything, so you didn't get bored. If you specialize, you're just pigeonholed into one thing. In family medicine, you can dabble in whatever sort of you want.
Okay. So you now live in Inverness?
Just outside, yeah.
And you practice in Inverness, of course?
Yeah.
Have you practiced in other places?
Yes, I did in Amherst for a little bit, and then in Tennessee for a bit, and then here.
Oh, really?
Uh-huh.
What were your expectations when you came to practice in Inverness?
That's kind of a difficult. I can remember the question I got, I was sort of interviewed over the phone with Dr. Burney. I can still remember being quite intimidated because when he called, I got the call from him. He was telling me about delivering babies and, as he called it, passing gas, which means delivering anesthesia in the OR and doing this and that and the other. And it sounded like he was some super doctor, which I think he probably was in his time. He did everything. And when I came, I thought I was going to have to do all this stuff. Anyway, that was, and the other three guys that were here, they were just an incredible bunch. These guys that were here. Dr. Locke is still here. I consider him one of the guys that seem to just do everything. Of course, Dr. Locke just keeps on going.
Keeps on moving.
Keeps on ticking, yeah.
Yeah. What, did you set some goals for yourself when you came?
No, I sort of wanted to do most of what they were doing. I wanted to do obstetrics, and I wanted to do ER, and helped in the OR some, family practice.
Okay. So obviously you progressed and you were enjoying what you're doing there.
Yeah, well, we don't do any of that stuff anymore.
Oh, okay.
We don't do the
that's true.
Yeah.
What are the unique challenges you encounter in a rural practice as opposed to an urban one?
Well, you have to be sort of independent. We don't have specialty backup. Would probably be the biggest thing. We're here by ourselves, and we sort of depend on each other to help us out. So that's, I'd say, probably the biggest one.
Okay.
You mean from a medical point of view, or from the
Yeah.
And I'd say probably getting the backup we need. So we're stuck here in the middle of winter, in the middle of a blizzard or something like that, and we can't get somebody out. And even in the good weather, it's sometimes hard to get out because the receiving people, we call them and they say they can't take somebody. And we get frustrated, we thinking, well, why won't they take them? But on the other end, they've probably got a hallway full of patients too, and they can't take them. They got
Other
their own
people
issues.
calling them in.
They got their own issues at the other end.
Yeah. What are the most common health issues you run into amongst your clients in rural practice?
Well, there's like a list. They've always kept a list of the 15 most common problems that are presented. Is that sort of the question you mean? Like,
well, what is there a clump of bone issues or skin issues or respiratory issues, things like that come in that on a regular basis that you have to deal with?
Yeah, I would think chronic obstructive lung disease would be way up there, especially in Cape Breton. ischemic heart disease, heart attacks, and
Okay.
There's a lot of cancers. And
Okay. What about the lung disease? Is that, you said in Cape Breton, is that?
well, smoking
Common?
was a big part of it. Yeah, which fortunately is getting less as people smoke less and look after themselves better.
Okay.
Diabetes is a big one, of course.
Okay.
Yeah.
Okay. What can people do to help themselves
Well,
diminish those things?
yeah, it's people think they can come to the doctor and get better. We can fix them with pills and medicines and stuff. They medicinize everything, but if they would, I don't mean that sounded wrong. I don't mean derogatory. I mean if everybody would just do
Some simple things.
eat right, live right, sleep right, exercise, a lot of these medical problems would sort of fade away, and it's frustrating to see somebody won't take blood pressure pill, cholesterol pill, and then they go out and have a heart attack, and then they come back and they're on 14 different pills. If they'd have just taken a blood pressure pill and a cholesterol pill and walked a little bit before, and it would save a lot of time and effort.
I think there's been a shift from, or by the health authorities, to try and maximize what people do to prevent illness. Do you think that the Department of Health is doing enough to work on preventive medicine?
Oh, I'm quite frustrated just lately seeing what they're doing. They seem to be doing just the opposite in some ways. They seem to be focusing on emergency care and not primary care. Primary care prevents things, obviously. Emergency care is just looking after the disasters, like the heart attacks, and which need to be looked after. But if you put a bunch of money into primary care and preventing the heart attacks, you're not going to have near as many heart attacks coming in your emergency room, and that doesn't seem to be the focus that I see happening.
Okay. And you spend a lot of time in the emergency department in your hospital?
Yes.
Okay. And given the limited resources and the distance from large facilities that will, have experts beside yourself, do you have extra challenges dealing with emergencies here?
Extra in what way?
Do you have to step outside of your routine knowledge and practice to handle some of the stuff that comes through?
Well, I guess we would, if you put one of us in the emergency room and something comes through the door, we're not able to draw from, a trauma surgeon or internal medicine specialist, or we're fortunate to have Dr. Locke here. We can quite often draw on his skills, but if he's not in town, we can't draw on an anesthetist to help us with airway management, or a pediatrician, or we have to be at that time the best pediatrician we can be, or the best anesthetist we can be, or the best this or the best that, for that period of time until we can get that patient out of there in the emergency situation, while all the time also looking after the other 32 people that walk through the door with the rash they've had for 3 years that shouldn't be there, that should be in primary care. So the triage thing is kind of frustrating.
Yeah.
Yeah.
I think you've answered this partly. In what are the significant or the most common emergencies that you encounter when you're working in the emergency department?
Well, there's not a lot of emergencies come in. If you look at the numbers that, if you had 100 people that register, the true emergencies are not very high. But if you took just the true emergencies that come in, I would think a lot of them would be related to airway and myocardial infarct or heart attacks, and then diabetics, and then pediatric emergencies. I'd have to look at the stats because I just, yeah.
Do you get a lot of pediatric emergencies?
No,
You don't?
they'd be low.
Okay.
Yeah.
Mental health seems to get a lot of media lately.
Sorry, I should have put that on the list. That's
okay.
yeah.
But it seems to be, or at least from my observation, it's becoming more in the news. And given the stigma that can be associated with it, particularly in small communities, is there different challenges for you and your colleagues when you're dealing with people with mental issues?
Oh, it's a huge issue. And if we had more help with mental health, there would be there's such a trickle down if you don't fix the mental health, and that's probably fed by other problems too. Probably their social issues that feed into. It's all intertwined.
Yes.
You know,
Yeah.
somebody doesn't have a job and they don't have supports, and you know, people come in these mental health crises, and it's just not the mental health crisis. It's so many other intertwined problems. Yes.
Okay.
Yeah. It's. I don't know if that answered that question.
Yeah. That's. I just find that I keep saying to myself, well, I think somebody is doing something about it, but are they? You know.
Yeah. Well, it's not an easy problem to fix. Someone comes in with one of these issues, and it's not just there's a pill. There's a counseling. You know, you say, can I get counseling for you? Well, sure. There's your appointment 3 months down the road. And even if you could get them into counseling tomorrow, is that going to fix them? Probably not. Mm-hmm. It's got to be, counseling, pills, social worker, help them get a job, help them get this, help them get that, and that all that intensive thing that's one person. We don't have one person. We got a whole bunch of them.
Yes.
So if we get to help all those people, we'd like to try. If you look at our mental health, they're fantastic people. They're fabulous. They do a great job. But we need a whole lot more of them.
Mm-hmm. Technology is playing a major role in everything these days, and particularly, I think, in medical or in healthcare as well, particularly telemedicine. Can you explain telemedicine a little bit for our audience?
Well, it's sort of a double-edged sword. There's good and bad to it. The good part about telemedicine is we get to access to patients can be seen, like oncology, for example. An oncology patient can be seen in Inverness by an oncologist over a TV screen, and the nurse, the oncology consultant nurse, can be in Inverness seeing the patient. If the patient needs, whatever touched or felt by the oncologist who's in Sydney, the nurse will do that, and the oncologist can see the patient. They don't have to travel down to Sydney. So that's very helpful, saves the patient, that travel down back and forth, and they don't want to drive back and forth there. And so a lot of the visits can be done that way. Very helpful. So that's a big advantage. Or I can do what's called a corridor consultant. I can call up or I can book a discussion with a specialist over the phone, and I can talk to almost any specialist fairly quick about a hypothetical patient and get some good advice. It works really well, and these specialists are fabulous to talk to. They're just an excellent service. But there's a downside of this technology too. All our medical records have gone to this EMR thing, an electronic medical record, and I see patients during the day, and then all these they're called tasks come back to me. So every time there's an ER doctor who orders a test, or a nurse practitioner orders a test, they all get sent back to me, even though they're normal. Sometimes I'll get 3 copies, 4 copies, 5 copies. I have to sign every one of those off electronically. Every time I go home at night, I'm on that darn computer. Sometimes an hour, sometimes 3 hours. And my secretary's on it every night too. We're doing all these stupid tasks that are just redundant and a waste of our time. And if we don't check them off, they just pile up. You go away for a week, you come back, there's 700 of them there. It's just, needs fixed.
How do you fix that? Or what is this? It's a big job.
Well, like one of the other doctors in my office, we tried to make ourselves, I called it Dr. X, instead of being Dr. Bennett and the other doctor. Well, we couldn't get them to do that. Such that only one of us had signed off. But anyway, they wouldn't bite on that. Anyway, there are fixes. It'll probably evolve.
It's going to take time.
Yeah.
Are the digital communication networks up to snuff in terms of being able to handle the telemedicine work that needs to be done? Like internet services,
speed-wise and stuff like that.
Yeah,
I'd say so. Yeah, they're pretty good.
Yeah.
The IT department here in they do a fabulous job. They're very good. Yeah.
That's good. Yeah, that's so important these days. The way things are going.
Yeah.
Is there a memorable experience you can share, or a story from your practice that highlights the rewards of working in a family practice and in rural areas?
Well, I think it's mostly working with the staff and it's the whole collective staff. I don't mean to be just going to say bad for the politicians, but I guess everybody likes to dump on the politicians. I was walking around. I was asked to talk to the premier. I won't tell you which premier it was. The premier was walking around with a bunch of his entourage, and they were talking about the doctors, how the doctors did this, the doctors did that, and everybody thinks the doctors are at the peak of the pyramid. We're the top, and everything trickles down. And I just don't like that. Anyway, there was a maintenance guy walking across the lawn down there through the window, and the premier's there, and I said, "Do you see that guy out there?" And I told him his name. I won't tell you his name on here. Anyway, and he says, "Well, yeah." I said, "If that guy doesn't come in tomorrow, doesn't do his job, this place falls apart. If I don't come in tomorrow, probably doesn't matter. There's going to be a nurse here. There's going to be orderlies here. There's going to be this and that and the other. The place is going to run. But if he don't come in," because they were just about to go on strike, I said, "You better fix that." That was, so the people that are around us are the most important. The nurses here are
support.
They're fabulous, and they just march along. They do all the work, and the doctors take all the credit.
Well, my experiences at Inverness have been very positive, and what you're saying is quite true. I've never had a really bad experience after 15 years of going to Inverness Hospital, and I've had major issues that I had to deal with. I'm still here, and it's thanks to those people who are your support staff and the doctors as well. But
but it's the people around us. I think that's the most important. It's a physio, just top notch, and the X-ray techs and the lab people. It's the nuanced things they do. It's they care about what they're doing. They care about. I think they care about the result a little bit more. Like if you go somewhere else, I don't want to put down about other places, but I think they know you a little bit.
Yeah.
Like when you go into that hospital, they know who you are, and so they're going to try a little extra harder to get that right image on the X-ray, and they're going to, if there's something on that X-ray, they're going to give me an elbow when they walk by and say, "Yeah, you better take a closer look at that X-ray, just to be sure." You know what I mean? It's just they all work together just to make sure the patient comes out the other side in good shape.
It makes the patient so much more comfortable as well when they're approached like that.
Yeah.
Speaking of emergencies, I happened to do a sort of a little survey myself the last 3 or 4 times I've been in the hospital getting blood work done or whatever. And I'm amazed at the number of people who are coming here to Inverness from the Cape Breton or from the Sydney area. I talked to 15 people, and 6 of them were from the Sydney area. And I said, "Why are you driving all the way here?" "Well, because I can get my blood work done a lot faster than sitting for 2.5 hours in the waiting room in Sydney. I can come here and get it done." And she said, one of them said to me, she said, the place is clean too.
Yeah.
I was amazed at that particular one. But it seems to be a staff thing too. Have said to me, we're really getting a lot of people from outside our usual service area. And what can be done about that? I don't know if there's anything can be done about it. But
well, again, I back to what I sort of said earlier. I just don't understand why the government's pushing all primary care into the emergency room. If you look upstairs, I have one secretary at a time. We support 3 doctors in one office. My secretaries are unbelievable how good they are. They manage patients. They manage the office. They are superb with patient interaction. They know how to they essentially triage patients every day. They know how to get the sick ones. They'll let people in if they're sick, but they'll cut people off if they're not. So that's one support staff I have for 3 doctors. Yet the government's taking the doctors out of primary care and putting them in emerge to make the short times waiter. They're focused on short wait times. So if you're a short wait time and you're a patient, what are you going to do? You're going to say, well, I'm just going to emerge. So you're just going to funnel everybody into emerge. And I'm not blaming the patients. If I'm down there in Sydney and I know I can go into Inverness, I'm going to go to Inverness. There's actually, I believe there's a website out there you can look and say, wait time here, 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 and here is, so you just go to the shortest wait time. So people are going to just move wherever. So that's their philosophy. That's what they decide to do. They're the government. They decide what to do. They decide where to put their money. They've decided to put a website out. So, if you're able to pull up a website to decide where to go to an emergency, I don't think it's a freaking emergency. I don't think. So, and if you can pull up a website to decide which emergency to drive 2 hours to go to, I don't know if it's an emergency. That's just my opinion.
Well, perhaps we need to redefine emergency.
Yeah, if they're going to decide to do that, go all in. Put everybody, do it single access, put everybody goes to the emergency room. And then there's perfect triage. And, if you're a sore knee for 3 years, great, go to the sore knee room. If you're cardiac arrest, great, you go to the cardiac arrest room. Everybody goes there. Mm-hmm. Don't go half in, go all in. Mm-hmm.
What, in your opinion, is the single most important thing that Nova Scotia Health could do to provide better support to family physicians, particularly in the rural areas?
Probably logistical support, like that EMR thing, and get rid of the extra stuff.
The burden of paperwork and.
I would say so.
Okay. What tips do you have for people that could enable them to stay away from the hospital and emerge? I think you've mentioned some of them earlier. So.
Yeah, it would be, think about your problem before you access and find out where your best access is. There's a lot of access to care that's not emergency. And the ads the government's got up there, I don't know if you've seen them, they are pretty good ads. They say, just think before you go to the emergency room. There's other ways to access care. I do appreciate those ads the government put on. Think about the internet-based care you can get. Think about private physio clinics. Think about this and that. Just think before you go to the emergency room. Because when you go to the emergency room, you're actually doing harm to other people if you don't have, real troubles. The thing is, we got 2 big problems. We have a hard time getting the people that ought to go to the emergency room to go. People that ought not go, stay home. Yeah. You have some of these older farmers, they're out there. You can't drag them to the emergency room when they're half dead. They just won't go. They're having a heart attack because they think, I can't go in there. I might be, taking a space away from somebody who really needs it. Mm-hmm. They're just, and other people that go there probably 20 times a year. I think that's going to be hard. I don't think you'll ever solve that.
I don't know whether you're aware of it or not, but there is a book, and I'm not trying to sell this book, but I picked it up. I was in Halifax and I saw it sitting in the bookstore. It's called Health Hacks. It's by Mary Jane Hampton. It's an interesting read. I read it just for curiosity, and I think it would be useful if people, had a peek at it, just to, and as I said, I'm not trying to sell the book, but I think there's some good information in there, following up on what you're saying as well.
Yes.
It's worthwhile, I think. Recently, you've combined your engineering and medical skills with one of your children, I think, and you're working on an invention to resuscitate people. Is that?
Oh, yes. I guess we must have talked about that.
Yes, we did. Yeah.
Yeah.
Talk about it a little.
Yeah, sure. That's my daughter Leah. She's in medical school. She, as part of a residency project, she took, if people out there don't know what an ambu bag is, that's what when you're helping somebody breathe when they're in poor shape. It's a bag that has air in it that you squeeze by your hand. And so she built essentially a robot, a small little robot that clamps onto that bag that squeezes it repeatedly. And she built a little computer that did it. She 3D printed the gadget that does this. And she did it. I've seen the gadget. I think maybe I even showed you the video.
You did, yeah.
And it worked. It was pretty cool. I was pretty impressed.
Yeah.
So the idea she had behind it is that this could go to third world countries, or sometimes even the back of an ambulance. Because when you're on the back of an ambulance, because I've done lots of these ambulance transfers, if you're bagging somebody, that's what we call it when we're doing that. It gets tough after a while. Your arm gets sore, and you can't do it as good as a computer. A computer will do it regularly, methodically, and get the air in. And you've got to do that, especially in certain medical conditions. If it's done nice and regular and methodically, the physiology of the patient is handled much better, and they're more likely to live. And so, anyway, it worked. She did very well. I was very impressed. She did a much better job than I would have done, I'm sure.
Does she plan to patent it, or?
I don't think. I think the idea has been, to some degree, done before, but I don't think it's been done that well. I'm not sure. I can't get into it that much.
Yeah, it'll be interesting to see her pursue it. It's kind of exciting.
Yeah.
Besides inventing devices, what do you do for recreation?
Well, to be clear, I didn't. She did.
Helped to invent. Yeah.
Yeah. I'm sorry. What was the question?
What else do you do for recreation?
I do putter around the house quite a bit, like building things, and I do plan on getting back into flying shortly. I've started to re-engage. I've got a pilot's license, so I'll start flying again. That's my
nice.
current activities.
Okay.
We like to travel a lot, so my wife and I.
Oh, good. Mm-hmm. Are you a fixed wing or helicopter pilot?
Fixed wing.
Fixed wing?
Yeah.
Okay. Do you have an airplane?
No, I'd like to buy one.
Okay.
I haven't told my wife that yet.
Yeah. Before we finish our discussion, is there anything you would like to add?
No, I don't think so. It's just it was a great choice to come back here. I was convinced to come back. Not really convinced, I guess. It was my mother-in-law that I spoke to. She was on the board of directors back when we had a board in Inverness. In a way, I think that was a shame those boards disappeared from the small little places. Because I think the boards directed what happened in small places. And I think we've lost something to have smaller areas, more controlled more by the local people. And I think if you look at Inverness, we're controlled by people outside Inverness. And I don't know if I like that.
Okay.
When I moved here, Inverness was controlled by not just Inverness County.
Yes, yeah.
Do you know what I mean? I don't want to isolate us from other people, but I think we had more control over what happened here. Okay. And
well, obviously the people have the knowledge of where they live and work.
Yes.
And I think
yeah. And I hear that from other people.
Okay.
Yeah.
Thank you very much for coming out and taking the time from your busy schedule to come and talk to us. And your challenges, and for providing insight on what you feel government can do to improve the system and what people can do to better self-manage their health. And thank you to our listeners. Please share these podcasts with your friends and neighbors, and subscribe to Highland Waves so you can stay up to date. It's free. Today's quote is by Dr. Pixie McKenna, an Irish physician and medical journalist who said to an audience of general practitioners, "As a general practitioner, I think that reassurance is 90% of your job, but equally as important is how you deliver it." So long for now, Pat.